Hello, everyone. This is Nairi from Low Carbon Fasting. Well, our guest today is a neuroeconomist. She's going to tell us all about it in a minute. That was the first time I heard of that specialty. So she's a scientist. She's a public speaker. She's a researcher, nutrition researcher and health researcher, actually. She's founder of the Stanton Migraine Protocol and author of Fighting the Migraine Epidemic, How to Treat and Prevent Migraines Without Medicines. Dr. Angela Stanton, welcome to Low Carbon Fasting.
Thanks, Nairi. Very nice meeting you. Thanks for inviting me.
I'm delighted to have you here. I've been looking forward to this for a long time, but I wanted to finish reading the book before I could invite you. So I would do you due justice. Actually, the book is over 600 pages of absolutely detailed and fascinating information. So I would recommend the book, and I'll put the link below as well for anyone interested in learning more about migraines to go and purchase that book. It's the only book that covers the nutrition side of migraines and how to treat it without medicines. Now, two things of note in the title of your book, Angela. The without medicine part, without medicines part, and we'll discuss that in detail. But the other one is, you call it migraine epidemic. Is it an epidemic, and why?
That's an excellent question. And of all the interviews I've ever had in the past number of years, nobody asked me that question. And I'm so glad that you asked this. And so let me give you an example right away. So when I started my migraine group on Facebook, which was 10 years ago right now, almost 10 years, 9 years, it was quite hard to get people interested. And over the years, as people came in, you kind of sort of got to understand the particular, percentages that they represented from certain countries. And so there are certain countries that were very tiny, remote countries like Northern European, Scandinavian countries. I mean, we would have maybe one or two people coming in, and those are very small countries. So you would think that, okay, so that's about right. And compared to the United States, it would be a much smaller number. Over the years, as those countries have turned more and more toward a plant-based diet, I'm getting more and more people coming into the migraine group today. Some of the Scandinavian countries, and I think it is Denmark, that is like the number 2 biggest representative population in my migraine group, and we have close to 16,000 members right now. So we're talking about a growing population based on our dietary choices and other kind of factors, which we're probably going to talk about. And so because it's increasing, I will have to say it's an epidemic.
So it is increasing, but also younger
Right.
people are being diagnosed with migraines now. That really threw me off. I mean, how can you diagnose a 2-year? How can a 2-year-old suffer from migraines, and with diagnosis being so complex? Because it
can though, because if you read some of the academic articles, colic, which is for newborn infants, right, is considered to be migraine for the infants. So migraine is genetic, and it can come at any age. So we have people who didn't have migraine all their lives, and at age 65, suddenly they're getting a migraine, and then they join. And we have people who start young. They have people who lose it when they enter into menopause. We have men who come in. Some of them lose it, some of them gain it. I mean, it really is an epigenetic factor of when migraine will actually be activated by the factors that surround you, or whatever factors you create for yourself with your lifestyle. It can happen anytime. So there's nothing surprising about having younger generations diagnosed. I was 10, 11, something like that, and I had my first migraine, but I was not diagnosed because they didn't realize that the symptoms that I had were migraine symptoms, only I had an atypical presentation. At that time, it was atypical. Today, I understand that most of the children present with the kind of migraine that I had. It's just we didn't know it was migraine.
Until I read your book, hadn't realized how complex migraines were. I completely had no idea that there were different types of migraines and that the symptoms could be so very different from people to people. But also, I think there's so much of an overlap with other conditions that it's not always easy to diagnose it correctly. And I think you cover that in the book. You say there's so much misdiagnosis of migraines. So what's the problem there? What's happening?
Okay, so there are many things that are happening. And so your question is very well taken, because we think that when you have a disease or a condition, which comes with very specific symptoms, then you should be able to identify what it is. But the problem is that, take, for example, aura. We associate aura with migraine, right? But if you have a seizure, if you get a stroke, if you hit your head really badly and end up with a concussion, any kind of traumatic brain injury, they all can come with aura. So having an aura doesn't mean that you have a migraine. And they have many people who had an aura and they were diagnosed, therefore, as migraine, but they don't have migraine. And it may just have been a situation that could very well have been completely random, and they ended up with an aura for whatever reason. Could even have been a head cold for all we know. It's just a disturbance neurologically that may cause that. And similarly, many of the symptoms that you mentioned, that in fact migraine is a lot more than just a headache, which is what everybody think about. In fact, you don't even need to have a headache to have a migraine. And over 20% of the population, of migraine population, don't even have a headache with their migraine. So a headache itself doesn't represent a migraine. It may or may not be part of it, but you have a host of other symptoms. It could be nausea. Vomiting is very common. I mean, nearly everybody will vomit. I mean, how often do you vomit from a simple headache? You don't. So clearly it is something else. Many people will be dizzy. They will be very sensitive to light, sound, taste, touch, odors. I mean, that's going to be extremely sensitizing. They will perhaps be irritable. They will have extreme urination right before migraine. That's a prodrome that they will be urinating quite a bit. So we have a host of symptoms that are not associated with a headache that is still part of migraine. So when they're diagnosed migraine, they need to look at all these symptoms, but all these symptoms like irritable bowel syndrome, IBS, for example, or restless leg syndrome, RLS, these are all symptoms of other diseases as well, just like nausea is, just like vomiting is, diarrhea is. And so when you're looking at all these symptoms individually, they all fall into different individual categories that can be part of other conditions as well. So unless you have a doctor who understands the whole picture, they won't be able to diagnose this migraine, particularly if you don't have the headache type form. And so we barely have any members in the group who don't get a headache with their migraine, because they tend to be dismissed as something else.
Yeah, that's interesting. So let's ask the question, is migraine a disease then?
No. If you can prevent it, and if you can treat it without medications, then what are the chances that it's a disease?
So it's not a disease. So what's wrong with the current medication?
Okay, so there are several problems. One of them is that assume that you have a migraine that also happens to have a headache with it. The medications are aimed at reducing the headache or make the headache disappear, but that didn't make your migraine disappear. So you still have a migraine. You just don't feel the headache part of it, but you may still be vomiting, throwing up, doing all kinds of other things. And so those are out of control. And if those are in control, or maybe you don't have them, because you don't have to have vomiting with every single migraine. Say you have a migraine where you're dizzy, you can't really speak too well, you're slurring, or you can't comprehend, you don't really know who you are, you don't know where you are, you recognize people, but you can't really you're sort of kind of out of it. And you also have a headache with it. And so you take a medication for migraine, and it's going to take your headache away. You're still going to be completely out of it, because it's not working with the rest of the symptoms. It's not going to take away your slurred speech, your inability to focus and concentrate, to recognize your spouse and stuff like that. It's not going to do that. So if you're taking a medication and you're driving on the road, you may still get into an accident as a result of your migraine, because it's not controlling your whole migraine. It is controlling one aspect of it. And so it is like, for example, having a broken arm and getting a medication for the pain, but not putting a cast on the broken arm. And then because you don't know that you have a broken arm because you have no pain and you continue playing with, a tennis racket, it's not going to be helpful for you. So medications really can't address the whole concept of migraine. One of the reasons why they can't address this is because they don't understand what it is. Now, some of the migraine medications sort of kind of attempt to associate itself, the medication, with what they believe is the cause of migraine. And in some cases, they come pretty close to understanding that that particular part is involved in migraine, but they're doing the wrong thing. So take, for example, a medication, the several medications that they give to migraineurs that are also given to seizure. So these would be like the gabapentin, topiramate, and a whole class of medications. And they kind of sort of on the right direction in terms of migraine, because they are blocking off of the voltage gated sodium, calcium channels. And these are basically primarily responsible for some of the things that are happening. But in the case of seizure, for example, these channels are overly active and they're hyperactive, and they have to shut them down, to stop them working so that they won't release a huge action potential. In the case of migraine, it's the other way around. They aren't working well because there's not enough electrolyte at that particular location, not enough sodium, and so they can't generate action potential. So when you block it, it makes it even worse. But they are aware that these channels are involved. And there are literatures out there that will say that migraine is in fact a channelopathy, which means that the voltage-gated ionic channels that function in basically operate your brain don't work for whatever reason. It doesn't tell you why they don't work, but they don't work for whatever reason, time to time, and that's when you get a migraine. So they kind of understand that those channels are involved, but they aren't looking at how they're involved and where they are involved. And one of the reasons why they aren't involved, I'm just doing a literature research because I'm about to write an academic article that may or may not publish, but I'm going to try one anyway to include my Stanton migraine protocol. And I'm doing a literature review just to see exactly this. Where is the literature? What does it say migraine is? And there is not an organ that is not listed under the auspices of migraine is caused by. I mean, it's absolutely ridiculous that they're going in every direction, but I have not yet found a single article that it would try to grab all these and see, well, what's common in all these and how would these work together? And what may be that stands out that, okay, this forms a unit that can. Not one of them does that. And so that is what I'm doing. And that is what I did with my protocol. I read all these papers before. Some of them are newer, so that's why I'm doing a review to see what new academic articles are in there that I can pull into this explanation of the Stanton migraine protocol, basically in this academic article. And I'm seeing that there's a lot of research, for example, on the electrical activity of the brain that is different in migraineurs, that the cortical spreading depression, which we can talk about, that it exists in only aura migraine. Articles say that, no, it's not just aura migraine, it's all migraines. Other articles say, no, it's not even there. I mean, there's so much confusion that it's very, unless you really stand back and you're not too close, because if you're too close and you're doing your research just within, say, the cortical spreading depression, then you won't see anything else because that is your narrow focus area. And it takes all your energy to focus in on that. But if you have colleagues or like me who are not involved with that research, but we can look at it from the outside, and as a migraine sufferer myself, I can say, well, do I fit that? Is this relevant to me? Is this relevant to the 16,000 other migraineurs that I know in my migraine group? Can this account for any of what's happening to them? And if yes, then I can incorporate it. Okay, so this may be part of it. And then it's my task to explain how it works. And that's basically what I do. So as you can see, the reason why it is so complex and why it's so difficult it is to even define what it is because we can't look into the brain. And humanly, we can't run any experiments on humans. Ethically, it's not. Even when we do experiments on rats or rabbits, even that is ethically questioned. Plus, we don't know if what they feel is really a migraine. So we're just guessing game. We have no idea. They can't tell us that they have a migraine. So we're just sort of kind of making assumptions. And oftentimes, because of misdiagnoses are so rampant, when they're trying to do a clinical trial, be it medication or for anything else, the people that they're pulling in for the clinical trial, how do they evaluate that they are migraine sufferers? If they can't even diagnose migraine, how do they know that the people they use for these examples or these experiments are in fact migraine sufferers? So we're facing multiple problems there. So hence the medications have problems because they don't know what to address because the questions have not even been asked properly.
Angela, you mentioned serotonin as a therapy in the book. Let's talk about that. And then move on to the electrolyte imbalance, which you just mentioned.
Mm-hmm. Right. Serotonin, though, is not really a treatment. Mm. Yeah. Triptans have serotonin in them. So there is one class of researchers and doctors who believe that serotonin actually helps migraine, but it doesn't. And people who take triptan, and I used to take triptan regularly, right? And they do work about 50% of the time. But if I replace triptan with a cup of coffee, it'll do the same thing. And triptans are vasoconstrictors. So basically what they work is because they're vasoconstrictors, but they only work in certain times because if I happen to have a pressure increasing or some other factors that would require my cardiovascular system to actually have vasodilation rather than vasoconstriction, then they increase the migraine. So even there, we have a problem. So serotonin is not participating. It's just the vasoconstriction itself that does.
Mm-hmm. So the electrolytes, you cover them in detail in the book. Let's start with the sodium and potassium, the balance, and why is it so important to migraineurs' brain?
Okay, so this goes back into what I put forth as the cause of migraine, which is that certain regions of the brain, for whatever reason, run low in sodium, in electrolyte. And one of the reasons why this is happening is because a migraine brain is anatomically different from a standard human brain. And this anatomical difference is that the sensory neurons, which are associated with, of course, our sensory organs like the nose, the mouth, the eyes, the ears, and the skin, the touch, the connections, not necessarily to all sensory neurons, I guess each migraineur is different, but for each migraineur, at least one of the sensory neurons are connected differently from people who don't have migraines. So migraineurs have a lot more neuronal connections. So let me give you an example for this. So say you're a migraineur and you have, like I do, very strong nose. I mean, I can smell like a dog just about. It's really ridiculous. If you take yourself, say you're not a migraine sufferer, and you get a flower, you're going to smell that flower and you're going to find it lovely. You give me the same flower, I may faint from it because I find the smell so nauseatingly strong. And that's because my sensory neurons associated with my nose that smells connect to a lot more other sensory neurons. So the message to me about the smell of that flower is this big. The message that goes into your brain is this big. So I'm getting a lot more stimulation out of that particular message. And as a result of that, the brain works with sodium. Salt is the one that initiates the action potential, which makes the communication possible. That's the electricity generated. So for that, the sodium has to enter the cell and potassium out of the cell, and this causes the action potential itself, the electricity. In the case of migraineurs, because we have so many more connections than a person who is not a migraineur between the sensory neurons, just this alone means we need a lot more salt in our brain. And if we don't have that extra salt, then our brain may not be able to cope with all that information coming in and passing the information on. And then that region is not going to function. And that's the start of migraine.
Mm. So where would that salt come from? Just the diet?
No. And this is very tricky to explain, but there is a big difference between salt that is consumed with food and salt that is taken with water. Mm. Your body is taking it very differently. Okay, so this is very complicated, and I don't know to what degree you want to get into it. And I did not spend too much time explaining this in the book that you read. Mm-hmm. But in the current edition, the third edition I'm working on, I'm planning to explain it quite a bit, but it's very technical, so it's very difficult to explain it fully. But basically, we have a digestive tract, so our stomach, in our intestines, the small intestines, and of course the large intestines, the bowels, the colon. When we eat food, it goes through the stomach, and from the stomach it goes into the small intestine and all the way through 20 feet of small intestine, absorbing all the food. And the food that is being absorbed this way absorbs whatever salt is coming from the food itself, and that goes into the cells directly, into the cells. But if you look at our blood test, and you look at your electrolyte panel in your blood test, then you're going to see that most of the sodium is in your blood and most of the potassium is in the cells. So you barely have any potassium in your blood. You have nearly all of the potassium inside the cells and most of the sodium outside of the cells. So you have very little sodium inside the cells. So if you're taking the salt with your food, it's going to get into the cells, and that's the wrong place to go. And so that way you will end up with hypertension and a host of other problems because it's simply in the wrong place. And salt, being an electrically charged sodium, basically everything is broken down in your body into the chemical, molecular, ionic form. So salt breaks into sodium and chloride. They have different functions. And so as this sodium enters the cells, because it's electrically charged, it can't come out. It can only come out if there's a trade-off, an exchange with something else, be it potassium or whatever else. And if that's not coming into the cell, the sodium is not going to come out. So that's going to cause problem because it's going to retain too much water inside the cell. It's going to cause a lot of issues. By contrast, if you're taking salt with water without food, it goes on the same path, but it absorbs really quickly. And it just goes in the very first pass in your upper intestines, goes into the blood. Because it has no food, it requires no digestion, it's an electrolyte. And so as something that is full of salt goes into your blood, so you're increasing your blood volume, which is the goal. Mm. You want to increase your blood volume, not the volume of your cells. So there's a difference between what is being increased. And so you want to add the salt to your water and not to your food. But when it comes to potassium, you want to take the potassium with the food, not with water. So you don't want to supplement potassium. You want to take that with your food, but you want to supplement salt with your water.
Why do you recommend full fat milk?
I don't recommend low fat milk. Where is the low fat milk?
Was it low fat or full fat milk?
It's full fat. It's
full fat. Yes, yeah. That's what I meant. Full fat.
Oh, I'm sorry.
I did say full fat.
Oh, I'm sorry.
It's the full fat, but why do you recommend milk? What's in milk? Is it the fat, or are there other nutrients in dairy that will help the migrainer's brain?
Okay, so first of all, migraineurs, there's certain percent of population who are lactose intolerant, and those populations are not present in the migraineurs much. Most of the migraineurs are not lactose intolerant. So we must be coming from the ancestral tribes that were ranchers and farmers who happen to be drinking milk. So for us, milk is a very good thing. We are not suffering from it like other people do. But also milk, like you mentioned, the fat. Yes, the fat in milk, particularly if you're getting grass-fed or pasture-raised, regenerative farm cow milk, if you have a chance to drink that, then you get a kind of fatty acids that are not in other kind of milks, because milk itself contains even ketones. I mean, it is a really fantastic product to consume. And that's why the mother will nurse the appropriate kind of milk, and human milk from the mother, once it's fully matured, it contains ketones. It contains very unusual kind of fatty acids. It's a very good form of nutrients. And also it is an electrolyte of sorts, not quite, because it contains fat and protein and other kind of things. And so it's more like a food per se, but it's also some amount of liquid. And because of the nature of milk, it is easier to separate the water from it than from other nutrients. Like if you're eating a soup, say a Boston cream chowder, your body will have a lot more difficult time separating the water from that for your body to be actually used as metabolic water. We get very little metabolic water from the food that we eat, but from milk it's easier because it is primarily water with electrolytes.
So you also recommend different types of cheese and so dairy. So so it's primarily the fatty acids, as you said.
Right.
How are they really helping the migrainer's brain? I can't understand how ketones and fatty acids would help the migrainer's brain. Is there a level of insulin resistance in the migrainer's brain, perhaps? Is there a inability to metabolize glucose, for example?
Excellent questions. You must have read my book. Yes.
I read it, all 600 pages of it. And these are all my notes.
Yes, you're right on target. So what I find is that, of the 16,000 people who are in my Facebook migraine group, I run a test that checks on their insulin resistance, in addition to the fact that I also have a blood test request. It's like a list of things that ask your doctor to order these tests. And a lot of the migraineurs go off and ask their doctors, and they may not get the whole list, but they get most of it. Mm-hmm. And I would say that about 90 to 95% of the migraine sufferers coming into the group have insulin resistance. And if it doesn't show up on their blood test, it shows up on the test that I run with them, which is a metabolic test, a 5-hour long. It's not an oral glucose tolerance test. We don't give them oral glucose. They're eating regular food, but it's a 5-hour postprandial test of blood glucose and blood ketones. And we know what they ate. They follow a recommendation of what they're supposed to be eating. So we have all the macros, and I have these normal charts of what their blood glucose is supposed to look like together with the blood ketones. And with the two, you can actually establish what insulin is because of the relationship of insulin with blood glucose and ketones. So you can then estimate what insulin is doing. And on that test, nearly everybody, I think in the history of our group, we only had maybe a handful of people who didn't show diabetes. And by diabetes, I mean any stage of diabetes, insulin resistance, hypoglycemia, whatever it is, it's all diabetes. Type 2 diabetes, just at different stages. And so, yes, all the migraineurs have a glucose metabolism problem, and their brain is different. I already mentioned with the neurons themselves are different, right? And they require different amount of nutrients as a result in electrolytes. And so not only are they sensitive to carbohydrates in general, but the whole body in the human body is set up in such a way that if you eat carbohydrates, the glucose that is taken out of the carbohydrates, when the glucose is taken to the cells, the glucose entering the cell itself is going to squeeze out sodium and water from the cell. So this sodium loss in the brain, where we already have a problem of not having enough sodium, causes an additional problem. And so it is very clear that a lot of people eating sweets, or now it doesn't even have to be sweet. It could be a potato, could be a cereal, it could be a slice of sourdough bread, which is really sour. But a slice of sourdough bread contains 15 to 20 teaspoons of sugar equivalent in starches. It's just not sweet, but it doesn't mean it's not there. And so when that converts to glucose in the duodenum, which is the first intestine, small intestine part immediately after the stomach, it converts to glucose there. So the person who ate a slice of sourdough bread has no idea that they are just right now digesting 15 to 20 teaspoons of sugar. And that sugar then heading into the cells via insulin, because that's such a huge sugar load. I actually have a table by Bernstein book that shows me the amount of how much your blood glucose increases for 1 gram of glucose, and 1 gram is a quarter teaspoon of sugar. So if you take 1 gram of glucose, given your weight, and that's without metabolic health status, it assumes that you have good, healthy metabolic status, how much your blood glucose will increase from that 1 gram of sugar. And if you're a typical adult female with a typical semi-normal metabolic health, you will have increased your blood glucose between 11 to 20 points, depending upon your weight. And by points, I mean milligrams per deciliter. So if your blood glucose was normal, say 95 milligrams per deciliter, and you ate a quarter teaspoon sugar, that's like a tiniest of bite of apple. I mean, I can't even think of a tiny enough apple bite. It will increase your blood glucose from the 95 to 106 or more. And so it will launch you into the status that insulin will have to be initiated to remove that excess glucose, because it's too much and it's too toxic then for you. And so when you're looking at it this way, a migrainer who is eating fat instead of carbohydrates is saved, because there is no there is going to be some tiny insulin spike for fat, but there's no glucose spike for fat. And so at least the sodium in the cells are going to remain in the cell. It's not going to be taken out by the sugar.
It's fascinating because I cover on this channel, we cover the low carbohydrate diet, we cover fasting, we cover insulin resistance, but I also, being a type 1 diabetic with an insulin pump and the CGM, I cover type 1 diabetes as well. And so much of that information is relevant.
Very.
To me personally. I don't have insulin resistance, fortunately, on top of my type 1 diabetes, but I am type 1 diabetic. And I found so much of what you say in the book, actually, even though I don't suffer migraines, but so much of it was relevant to me personally, to type 1 diabetes. Who would have thought?
Absolutely. And we have a couple of type 1 diabetics in the group, and there's 2 people. One of them was not type 1 diabetic in the natural way, but became type 1 diabetic metabolically after type 2 diabetes. And he reversed it and is now free from insulin. He was in a hospital for about a week, and I don't remember now the full details. He joined us maybe 3 or 4 months ago, and is now without insulin, navigating his way of eating the carnivore diet. And it's very, very fascinating that he regained some of his abilities with the pancreas to use it. But again, he wasn't born that way, and it's not a viral or infectious kind of type 1 diabetes. So,
yeah, good for him. I'm happy to hear that.
Were you born with type 1 diabetes? Or
I wasn't born with it, but I was 5 years old, so I've lived with it for 45 years now. So my time has passed, but I'm happy it's type 1 that I have, because it's manageable. I can manage it. I'm doing a good job. And the carnivore or animal-based food sort of heavy diet works like magic for diabetes, all types of diabetes, actually, including type 1. So I'm happy it's a disease that I can manage, which is the same for migraineurs. There must be happy people who are following your protocol.
Right.
And I read the testimonials. It must have been a life-changing experience for them, having suffered with migraines without hope for decades, and then suddenly to feel free of those symptoms. It's life-changing experience. So let's talk about the Stanton protocol. You already mentioned the importance of sodium, the importance of, we didn't cover other electrolytes. So what are some of the other electrolytes which are important?
Okay, so the other electrolytes are also all important, but we're not taking them the same way as salt. So for example, potassium, as I mentioned earlier, we don't take them with water, because those have to be inside the cell and not in the blood. So if you're taking potassium supplement, your blood potassium can increase and it can kill you it's really a dangerous situation. You really don't want your potassium, blood potassium, to increase. So we try to eat high potassium meals. We balance it with sodium, because actually in our body, if we took our body apart and we melted everything down and we looked at how much sodium, how much salt, how much potassium we have in us, by weight, the amount of sodium, not salt, but the amount of sodium and potassium are equal. By number, we actually have more sodium, because sodium is smaller than potassium in a molecular sense, and sodium is just half, right? It's 40% of salt. So when we're looking at salt, we have 2-3 times as much salt in our body as we have potassium. So the salt is a more important element. And then we have calcium and magnesium. So calcium, we don't supplement, because first of all, migraineurs drink a lot of milk and eat a lot of cheese. And so we don't really need calcium that much. And it seems that some of the papers that I'm reading that looked into calcium within the cells, it seems that in migraineurs, the intracellular calcium is higher than for non-migraineurs. So we are blessed with more calcium inside our cells, which can backfire. But if it's worked properly, then it's fine and we don't get any problems. And the last electrolyte of consideration would be magnesium. And magnesium is very important, but migraineurs react to magnesium differently from other people. For us, magnesium is an excitatory mineral. And so whereas people at night take magnesium for rest, if you're a migraineur, if you take it at night, you're going to be up all night having vivid, wild dreams, and you're not going to be sleeping. So we are not taking magnesium at night, but we are taking magnesium, and we're taking a full RDA dose of magnesium every single morning, preferably before 3 p.m. Like I don't eat before 2 usually. And so I will start my meal with my magnesium, because I don't want to take it later than 3 p.m. But yes, we are very strong on taking magnesium. And so we're taking that. And we're taking a couple of other supplements that are not electrolyte oriented. We are taking a very special B1 thiamine, which is a TTFD, is tetrahydrodisulfate, whatever. It's a long word. So it's just, let's stick with TTFD, which is extremely important for all people, not just migraineurs. So everybody I know in my family, I put on TTFD B1, but it's especially good for migraineurs as well. And for B2, I recommend the active form, which is the riboflavin 5-phosphate. That's the only active form. And so we're taking, these are the supplements that we're taking. We're not taking potassium and calcium, but we're taking the other ones. And these are very important for us. We're not taking anything else. So there's one additional thing that migraineurs come to me all the time, which is the MTHFR. I don't know if you were going to mention that under a different scope or not, but I thought I'd bring it under the supplements because we're talking about the electrolytes, is that MTHFR is a variant for the B12 or B9. And if you go to any doctor, any literature, they always tell you that migraineurs have this MTHFR variant and they need to supplement B12 and B9. But when I look at, the genetic variants, only about 50% of migraineurs have these genetic variants, which is the same as the general population. And of the 50%, only less than a quarter actually have it expressed, meaning that they show on the blood test that they need a B9 or a B12 or something similar. So the rest of them are not relevant. We're not supplementing anything unless we show some blood test for a need.
So we covered some of the vitamins as well. How about other minerals like selenium, zinc, iodine? Are they important?
Yes, actually iodine, I'm glad you mentioned, because we are also supplementing iodine. I forgot about that. So either supplementing iodine or taking iodized salt or both. And that's primarily because our food is so void of iodine. And so I would say nearly all of the people joining my migraine group, particularly women, have hypothyroidism. And that's just the lack of iodine. And so by now, everybody is taking iodine. And everybody who is taking iodine and had hypothyroidism is reversed, and they're off of all their medications. So that is, again, it's not just for migraineurs, but for everybody else. And selenium, we don't supplement because our food is very rich in selenium. So we don't actually need to. And zinc is a very interesting one. If you're taking zinc as a pill for supplement, it really isn't doing you any good. It's not really absorbing anywhere. You probably have heard during the so-called pandemic that we had recently that you need an ionophore to get the zinc inside the cells, right? And so unless you have that ionophore, you can't get the zinc into your cells. So there's no point of taking it. And in testing with blood, so far I've been going through probably thousands of blood tests, and so far found maybe 2 people who had low zinc. And I just told them have some oysters. I mean, it's just that simple. But if you're coming down with a cold or flu or any kind of virus, then not the pill, but a lozenge that you can very slowly dissolve in your mouth, so that, because the zinc works on contact, it's actually an electrical substance that will zap the virus and bacteria or whatever you have it on contact, is going to zap and kill them. It's not going to work once the bug is in you, in your blood, and inside your cells. It's not going to do any good. But if you have a sore throat, take it.
How about the liquid form?
It really doesn't help you anymore. Zinc is zinc. It's a metal. It can't get into anywhere unless it's being taken in there.
Let's come back to the magnesium you mentioned earlier on. So for migraineurs, it's better to take it during the day or with food rather than at bedtime. Are we talking specifically about a certain type of magnesium? Is it the glycinate, citrate, or whichever one? Or does it make a difference?
Yes and no. So let me explain. This is, again, chemically is very complicated, but magnesium is the thing that we want to take, and all magnesium can't be on its own. It's a very reactive substance. So there's no magnesium anywhere on the planet unless in a chemical lab where it is just magnesium. It doesn't exist. It's a charged thing. And so it has to be connected to something. And so the question is, what is connected to, how well it's going to affect the driving of the magnesium into the cells. So basically, we're looking to see the magnesium glycinate. Then that means a glycinate is going to be an element that is tasked with taking the magnesium inside the cell. Can glycinate do that? And so you have to look to see these other secondary elements that the magnesium is connected to see what they can do. So there are magnesium, for example, magnesium oxide. A lot of people go for magnesium oxide. But what does oxide mean? Oxide means it's already oxidized. What can that do? Nothing. It's already spent. It's already done. So taking magnesium oxide is going to make it highly inactive. There's not going to go anywhere. So there's no point of taking magnesium oxide. So you got to look at it from this perspective, that you want to get this other chemical, something that your body actually needs and uses. So when you're looking at glycinate, what is glycinate? Glycinate is an amino acid that you find in meat. It's like 20 amino acids. One of them is glycine. So magnesium glycinate is the glycine with magnesium. Perfect. Magnesium taurinate. Perfect. That too is an amino acid. Magnesium citrate. Citrate is fine. That is part of the metabolic cycle. Magnesium malate is perfect. It's part of some other cycles. So anything that could be part of your body as part of something or operating something will work. And oxide will not do anything. So you kind of have to look into. So I designed some supplements. I designed 3 altogether. One is magnesium, electrolyte, and vitamin D3. And I designed these basically for me. And I wanted to buy them from, there are a couple of pharmaceuticals you can order your own stuff and buy, but you have to buy a truckload. And I said, I don't care. I want mine, and I'm going to get it. And my son said, no, Mom, I'll buy it for you. So that was for the salt, the electrolyte. And so he bought it for me, and that was a truckload. And so he said, okay, so you're using this, but it's so much. Can we also sell it to other people? And so a company was started by this. And so I now design supplements for them. I'm not involved with them, but it's my son's company. It's his second company. It's a side company for him. And so sells supplements to migraineurs at a big discount. And I get my share free from the truckload that he's getting. So that's my connection. And so I select the kind of products that I know are good and qualify for a good absorption and totally pure. And so the magnesium that I designed contains the glycinate, malate, taurinate, and citrate. So it's 4 different kind of magnesium connections with the elemental magnesium in each capsule.
So we talked about the minerals, electrolytes. I think we talked about all the important vitamins. Does C play a role, vitamin C?
Yes and no. So it depends on a person. So I find it's not specifically migraine specific, but I find that maybe within the migraine population, it's more than outside of the migraine population. I don't know. There are more people who are unable to work with vitamin C. I'm one of them. If I don't take C, I'm going to end up with bruising, internal bleeding, and all kinds of issues. And it's not going to be the typical scurvy kind of a thing. It's a genetic thing, because what I found is there are some comorbidities with migraine, and one of them is Ehlers-Danlos syndrome. I don't know if you're familiar with Ehlers-Danlos, are you? Mm-hmm. Okay, so for those who are not familiar with it, it's basically a connective tissue disorder. And but there are a lot of little nuances with Ehlers-Danlos syndrome, which is called EDS. So there are a lot of little nuances, and one of the nuances is this bruising and the inability to work with vitamin C. So I find that in the migraine population, there are many people who need to have vitamin C, but this may not be so outside of the migraine population.
Right. How about the macronutrients? Let's cover the macronutrients and how they can help, or which ones migraineurs should avoid. You cover that in the book. Okay, so we're talking about proteins and the fats and, of course, the carbohydrates. You already mentioned the importance of fatty acids. Let's talk about fatty acids first. How about fatty acids from non-food sources like MCT oils and or even exogenous ketones? Do you have any experience with those?
I do, and there's nothing wrong with them. But in my groups, I don't recommend them. Primarily, well, for more than one reason. One of them is that we measure blood ketones. Mm-hmm. And so if somebody is taking ketone supplements or MCT oils, we can't really tell if the ketones is just a bunch of MCT oil that they just ate now, or if it's really truly ketones that they're developing. And the problem with ketones is that they interact with some of the medications. So for example, somebody coming in a group and still taking topiramate or Topamax, it's on the label that you should not be on the ketogenic diet while you're taking Topamax. And so it can cause a host of diseases, including kidney stones. Now, there may be some completely independent reasons for those kidney stones, like the fact that on the ketogenic diet, people eat a lot of vegetables that are high in oxalates. Mm-hmm. That could be some kind of a connection. I don't know, and I haven't looked into that, but I would like to avoid any kind of interaction. And I found that also ketosis can interact with some heart medications. Like I have POTS, which is a postural orthostatic tachycardia, and I've been on medication for like 30 years for that. And the first couple of months when I went on the ketogenic diet and ketosis, that was like about 8 years ago, I immediately had a major interaction with heart palpitation and other kind of thing. It took 3 doctors to figure out what was happening. And so some of these medications can become quite weird in a ketogenic environment because the expectation for these drug clearances is in a carbohydrate environment or a fat environment, not in a ketogenic environment. And so I am not in support of, as long as a person is still taking medications, I'm not support of taking any kind of ketone supplements or MCT oils or anything like that. With this said and done, we have a couple of people in the group who are already experiencing some cognitive difficulties. And if they're experiencing cognitive difficulties, which migraineurs may be more susceptible to as a result of all the brain changes, if they're already experiencing that, then I will recommend them to get on the ketogenic diet. So I have two groups. The other one is a ketogenic group. Most migraineurs are not in that group and they don't want to be. So that's a small group, only 1,700 people. But those who have cognitive or those who had significant liver damage from the non-alcoholic or alcoholic, whichever the case may be, coming off of this the standard American diet, I will also put them into that group to go more on the fat-based diet, because that's also healing for the liver. So you can have a variety of options. Now, the liver can't use ketones per se, but you want to force it to use more fat-based operation rather than glucose-based operation. So the liver makes the ketones but can't actually use it. And of course, the brain can use glucose or lactate or ketones. So the brain can use it. The brain can't use bigger fatty acids. But in your body, everything but your red blood cells can use just fatty acids. And so there's a benefit to an increased fat regimen, but not necessarily an increased ketone regimen, because when we look at ketones, only very few organs actually used ketones. And so when you take ketones or you're in ketosis, the primary direction for the ketones is your brain, and the secondary is your muscles. And so the rest of your organs may or may not switch to ketones. That's really, they use fat. So they don't need to necessarily switch over to ketones. Ketones are fat, it's just a smaller chain fat. So it's basically very similar.
So proteins.
So protein, I have a very special take on protein. Hold on. I'm very protein. I'm a protein-friendly person. I'm a protein body, okay? And I'm more protein body than a fat body, which is kind of unusual because today everybody is more fat body than protein body. But I believe, after reading a ton of academic articles, books, watching all these YouTube videos and all these pro-protein, against protein, carnivore, whatnot, kind of other experts, in my own experience, particularly in the group, is that protein is absolutely vital, particularly when we're talking about women. And the older the woman, the more protein she needs. It's really interesting that in my group, there's several women who went to test. I mean, everybody who passed, I think 65 is when we get the DEXA scan for the bones to see, right? I'm way past that. I'm past 70 now. So I don't even remember that period, but there are several women in the group who had the DEXA scan and they came back with osteoporosis, which is already having significant bone loss. So somebody just came back recently with minus 2.5, I think, and -1 is osteopenia, something like that. Then that's how much bone loss there is. And then we had one over 2 years ago, I think. She joined us. She joined us earlier, but that's when she went for the DEXA. And she also fell a lot and had bone fractures. And so she went on the carnivore diet in the group. And she just had a new DEXA, I would say about 6 months ago, maybe 7 months ago. She no longer has osteoporosis. And so we had just had another one who came through. She's even younger in the group. And she went, she didn't even try. She's not even on the carnivore diet. She's eating what we call the protocol proper, which is the low carb, high fat, but it's a higher ratio of protein. And I will explain in a minute of how that one works. But she too went from -2 to -1, 1.2 or something. So she to move from osteoporosis to osteopenia. So this is a very big thing because these women were not taking calcium, were not forcing exercise, and they were doing nothing. They just ate a lot of protein. And so when you look in the literature, you discover that 40% of your bones is actually protein. It's not calcium, it's protein. Then there is a lot of fat and other magnesium and connective materials to dig it in there, and then some calcium on top of it. But calcium is a secondary product for the bones. So protein is the most important. And protein is also the most important for your cellular recovery, because we talk about protein synthesis all the time, right? And we think about the athletes going into the gym and coming out with big muscles. But that's one form of protein synthesis. But the everyday regular protein synthesis is to replace your skin. Like our skin is on us for 3 months. Every 3 months, we have a brand new layer of skin. Well, where does that come from? Protein synthesis. Our stomach cells replace every 2 to 3 days. Our intestinal cells, colon cells, 3 to 5 days. Our blood cells, 3 to 4 months. All of these are made of protein. So we have to look to see the synthesis of these elements and all the little organelles in every single cell. Those are all made of protein. And so you have to, at the base, even our neurotransmitters are made of protein. Everything is made of protein in our body. So when you're looking at it this way, you have to look to see how important that is. So I am very protein focused. And so what that means is that it doesn't matter where you come from and what you eat. You have to eat enough protein to meet your leucine minimum. So leucine is a branched chain amino acid that is basically a signaling, actually ketogenic amino acid. There are 2 ketogenic amino acids. And so this is one of them. And so it will signal if there is an enough bolus amount of leucine in the blood. It will signal for the start of the protein synthesis. And if you have enough supporting other amino acids, in other words, it's not enough just to pile in a supplement of leucine, which you can buy on its own. That's not going to do you any good. So you need to eat the full protein of all the amino acids. And so if you have a full protein of all the amino acids behind it and some fat, you don't need to have carbohydrates. Everybody says you need carb because you need to spike insulin. Well, 80% of the amino acids are glucogenic. They will spike insulin on their own. So you don't need to add any kind of carbohydrates. And so I ask everyone a minimum 3 grams per meal in leucine they must meet. And oftentimes, the older we get, of course, the more leucine we need. And so like for my age, I probably need 4.5 grams of leucine because I'm over 70. So if you're looking at it this way, and then we have some members who are over 80, they will probably need even more. And at one point, we probably have to take so much that we can't even synthesize anymore because there's also a maximum length of time for which we can synthesize. And so I try to, at each age, so we ask the person, how old are you? And then we sort of kind of custom tailor. And also remember that blood test I mentioned earlier that they take for 5 hours. On that is the blood sample is taken every half an hour. And I can see, and also blood ketones, and I can see the line. And I can see there are huge ups and downs. There's no protein synthesis, but it's pretty steady with one spike at the beginning in particular, where the insulin is also spiked, and then just mini spikes up and down. Then I know they're synthesizing. And you can see the start and the end of the synthesis. It's really nice and easy to see. And so I try to aim for everyone to reach that status where they, no matter what they eat, they will synthesize protein for a significant number of hours. And so I will focus on protein in whatever way that they eat. They will have to focus on protein.
Angela, you mentioned the leucine. So let's talk a little bit more about that. And how does it link to brain health?
I don't know if leucine has any direct connection to brain health. I haven't looked into that. That's something to look into. Have you heard of anything on that? Is there a connection there?
No, but I'm wondering how it helps migraineurs' neural pathways.
Well, it doesn't.
It doesn't.
It doesn't really. So the only thing that the reason why it is so beneficial is because it's not glucose. And so it's not like carbohydrate that you eat. It doesn't initiate the insulin in your mouth. It's whatever glucose is going to be converted from the excess protein that you ate, or if you didn't eat enough protein and you didn't start protein synthesis, and you will have some glucogenic activity. It's not going to be like you eat a sugar. It's not going to instantly release a lot of insulin. It's going to be releasing it as needed. So it's going to be on demand. And so it's not going to be effective that way. It's not really affecting migraine in any way. In fact, it's good for migraine because it doesn't cause a sugar crash. Even if you ate too much protein and you end up with protein sweat, which sometimes happens to people, then we eat too much or too little and we never started protein synthesis, even that is not going to react the same way as if you ate an equivalent equal amount of sugar to whatever sugar the protein is converting into. So it doesn't work the same way. And so I just find that eating a lot of protein just simply reduces the need for all the protection that we created around eating carbohydrates. So it's just simply preventing that from happening.
Mm-hmm. Mm-hmm. I loved it earlier on when you mentioned osteopenia and osteoporosis, because last year I went for a DEXA scan, and I was on the upper end of osteopenia. So I think like 0.1, I only needed 0.1 to get to the osteoporosis phase. So I was horrified. But of course, I'd been a vegetarian for 30 years. So now with meat-heavy diet, I did the DEXA scan again when I was in San Diego a few months ago, and I've actually reversed.
Fantastic.
Hate osteoporosis, but I've actually reversed, and my bone density has increased. So I was really pleased with myself. I have to say, it's also strength training. It's not just the protein, but the protein is playing a role. So let's talk about the collagen then. Does it play any role?
Well, yes and no. So collagen, a lot of people end up taking just collagen supplements or collagen powder. Those don't do anything for you because those are incomplete protein, right? So you can't really synthesize it into even collagen, because to create collagen, you need to synthesize your protein. That's how you create a collagen. So it's not actually going to be used as such either. I mean, it may taste good. I don't know. I never ate it, so I wouldn't know. But if somebody wants to have collagen-like products in their food, then have protein powder, because at least the protein powder is a complete protein and it will create collagen as well. It doesn't make any difference. I eat a lot of protein powder. So and not just protein powder in milk or water, but as food, I replace flour in my food with protein powder. It's fantastic. So we create bread-like substances, which is called the modified soul bread, and some other elements, pizza dough, everything we can create with basically protein powder. So it's fantastic.
So which protein powders would you recommend? Whey? Are we talking about whey protein, which is pretty popular, or we're talking about egg whites?
Okay. So never egg white, because egg white is actually highly glucogenic. So if you want to have glucose for energy instead of an apple, then have egg white. So if you're going to the gym and you want to use sugar for your powerlifting, have egg whites. But to protein synthesize, that's not going to do you any good. It doesn't even have fat. It can't start it. So it's not a very good thing to do. You can have whole egg powder if you find that. You can find egg yolk powder and egg white powder. That's fine. You can use it. But I use actually a combination of many, many powders. So I'm using whey protein powders, as well as casein protein powder, as well as milk protein powder. Milk protein powder is a mix of, I believe it's 80% casein and 20% whey. You can buy it as milk protein powder. So I buy it as milk protein powder because I find it richer. It's a little bit denser. So you don't want to, if you're drinking a protein shake, you don't want to have the milk protein powder because it's going to be too thick. You would then want to have the whey protein powder. But if you want to make into, say, a muffin, or you want to have like a chaffle, with the egg and the protein powder, or you want to have a pancake, I make my pancake. Now, these are all unsweetened and unflavored protein powder. So there's no sugar, no sweetener, not even artificial sweeteners, nothing. And so nothing is sweet, but I will use the milk protein powder, which is a little bit thicker, to make pancake. Mix it with egg and milk or cream, and with the milk protein powder, and I can pour it on my pancake maker, and it's gonna make perfect pancake looking things. And of course, I will top it with cheese or whatever, and eat it with my bacon and whatever I want to eat. So I'm using all kinds of proteins, and I even bought the beef protein powder. I haven't tried it yet because I've seen recipes for bread made from beef protein powder, and it looks very intimidating. So I haven't yet tried the recipe, but both my husband is not a migraineur, and he's a big workaholic person. He works out every day and lifts weights and hikes and does all kinds of stuff. He's in a very good shape. And he and I both eat the bread equivalent, this modified soul bread that I create. And so we are addicted to that completely. We eat it with everything. It's fantastic. And it's pure protein. And it's very tasty, and it has a texture similar to bread, not exactly the same, but similar to bread. And it's very satisfying. So eating it with anything is just perfect.
Angela, I will move on to some other food items. And I'm excited to hear back. I mean, you do mention some of these, but before we do that, now the casein. There is an addictive element, and there is some research showing that there is an addictive element to casein in milk.
Right.
Now, with the migraineurs' brains, which we already know are over or can be over excitatory.
Yeah, excitatory.
I'll try to repeat that. Okay, so can casein be a problem?
So far, in a group of 16,000 people, we found 2 people who had that as a problem. And that's casomorphine that you're thinking of. So it's a morphine-like substance in casein. I have not, just these 2 people who felt that as long as there was cheese in the fridge, they went for the fridge. Otherwise, other people, like I can have the milk and the cream and the cheese and whatever for days. I may not go. It depends on a lot of genetics. Like I don't have an addictive personality. I know that. Like there's also alcohol, the drugs. I have not gotten addicted to anything in my life. So I happen to be a genetically blessed person who doesn't have that problem. So I think that this is very much based on genetics, whether somebody is going to be addicted or not, and to what they're going to be addicted. So we can't assume that just because casein contains a casomorphin, that everybody who's eating casein is going to be addicted to it. And so, for example, I often make casein balls for my husband. So I just get casein powder mixed with cream, and then I roll it in unsweetened cocoa butter to just a decor. And he will pop it every now and then when he just feels like getting a little bit of protein, increase. It's not addiction, so it's not like he's going to go after it every single day. It's going to be in the fridge sometimes for 5 days and he won't touch it. So not everybody will go and get addicted. So we can't say that it is addictive. We can say that there are people who are sensitive to that substance and will become addicted. But I don't think it goes for at least 99% of the population. It's not an issue, at least not in the migraineurs group.
Mm-hmm. Okay, so we talked about nutrition. How about teas and coffees, coffee and tea?
Okay, so tea, we don't actually allow in the migraine group. Because tea, any kind, even the herbal teas, they're a diuretic. So they dehydrate. And so one of the problems with migraineurs with electrolyte is the proper hydration. And so we don't recommend teas at all. Plus, excuse me, tea is also high in oxalate, right? So there really isn't that much of a point of having tea. And we have a lot of people from the UK. And I always joke about, the tea and scones. And they scolded me the other day that you think of us as teas and scone. I said, well, that's the stereotypical view. But so I don't support tea. And so people, even from the UK, when they join, they will replace it with broth. And some of the UK members will put cream into the broth and they say it's terrific. So that's great. Coffee, we use coffee as medicine because, as I mentioned at the very beginning, that a tryptophan benefit is really the vasoconstriction, and caffeine is a vasoconstricting element. Mm-hmm. So people who have a problem with drug overuse, so say triptan overuse headaches, which is a problem if they take more triptan. In fact, just yesterday, I had a fight with a doctor on Twitter or X because somebody was asking how much triptan I can take. And he said, you can take up to 2 a day. And I said, that is totally wrong. You can take 3 a week max. And if you're lucky, in some cases, even just 2, but 3 is the medically allowed. And I said, that's not true. And so the problem is that doctors are misleading their patients, and the patients are taking what they're told, that they can take 2 a day. But then it creates a rebound situation where the patient is going to have a headache from not taking it. So that would be a classic rebound situation. So it's not like they have a migraine. They have a terrible headache because they didn't take their triptan. So their body can't function without a triptan. And that's because of the vasoconstricting effect of the triptan. And so coffee is similar. So if you're used to drinking a lot of coffee, the caffeine is going to have the same effect. Tea also will have the same effect. In fact, tea is even worse because the caffeine in tea, depending on the tea, can be stronger than the caffeine in the coffee. It lasts longer, and it's just a stronger caffeine element. And so for this reason, we restricted coffee to 1 small cup, just 6 ounces, which is really a small cup of coffee a day. And they can have a decaf as well, or they can have 2 decafs. Like, I don't ever drink coffee. I used to, but I don't anymore. So I may have a decaf once or twice a week, which I just feel like eating with a lot of cream. So I just basically have a decaf for the sake of flavoring my cream. And so we don't really want it. But if they're tapering off of triptan, then we ask them to, before taking the next triptan, try coffee. It may work equally well. And more often than not, it does. And they can just simply taper off the triptan by taking coffee all the time, and then taper from the coffee very slowly. And so it's a tool that we use. It's basically, and also if they go a vacation somewhere and they can't control what they eat, because our macros are pretty strict and they have to weigh the scale and they have to calculate the macros. If they can't do that, then we ask them, well, have a cup of coffee with you that you can use. And also for the potassium to balance properly, and it has to come in food. So then we have them have the freeze-dried coconut water powder, which is unsweetened, unflavored. It has some carbohydrates, but they put it in water and they drink it, but it's food. So it's not like potassium in water. It has carbohydrates, fat, whatever it has in it. So then they can have that. So we sort of kind of manipulate these as medicinal use, so to speak.
Well, this is getting exciting. So herbal tea, we mentioned the herbal teas. How about the artificial sweeteners or even the natural sweeteners?
Okay, so I tell everybody in my migraine group, and not just migraine group, but elsewhere too, and I go by that. If I want to have something sweet, I will have sugar, because at least I know what it will do to me. The problem with the artificial sweeteners or the naturals is that they still spike insulin. We know a lot about them, like stevia will damage the gut flora. We have all kinds of other issues as well. But just outside of that, we had many people coming to the group saying, I have no problems. I have stevia and I'm doing really good. So then we have them have their usual breakfast, and we do the blood test, the 5-hour blood test. And many of them say, well, I'm just having a coffee with my stevia, and that's my meal for breakfast. This is fine. So then you do that for your breakfast, and we're going to see your blood test for 5 hours. And without exception, about 2 hours after the stevia or monk fruit or whatever other sweetener they use, a spectacular sugar crash. I mean, spectacular. In a half an hour, they can be going from 100 to 65. It's absolutely milligram per deciliter. It's absolutely magnificent, spectacular sugar crash. And they don't feel it. And because they don't feel it, they think they're fine. But then they end up getting with a migraine, and they think, well, they must have had something, that some trigger, whatever it is. But actually, the trigger was a sugar crash.
So
that
sugar
causes
sugar
right.
crash because the body probably spiked or released a huge amount of insulin in response to the sweet taste.
Exactly. And so people forget that we release insulin just for TV commercials. I mean, think, why would there be TV commercials for foods if they didn't spike the insulin? I mean, the whole point is a Pavlovian effect, is that you think of a lemon, you're going to get your saliva drooling as a result of the sourness of the lemon, right? I mean, our body is primed to be ready for whatever is coming. And if you're looking at a donut, you're going to release insulin. Whether you're eating that or not, you're going to release insulin. And if you're putting sweet in your mouth, it could be lead. Lead is sweet, by the way. That's why lead paint had to be removed, because kids ate it. I ate lead paint when I was a kid, just a little bit. And my mother would catch me and I would be pretty much punished for that. But it's sweet, I can tell you that. And so it will release insulin. It doesn't need to be food.
Last on my list of sort of foods and drinks is water. So why is hydration so important?
Okay, so water is not hydration. So we have to split it into two parts, okay? So if you're looking at the chemical properties of water, water is a solvent. So you can put water into stuff and it's going to dissolve it, right? I mean, look at what happens with iron. It's going to turn to rust. It's going to destroy it. So water has molecules in it that high in oxygen. It's going to attack everything because water is actually charged, both on the oxygen and on the hydrogen end is charged. That's why you can see body of water as opposed to a single molecule. And so when you're talking about water, if you drink water, because it is charged, it's going to take the salt, the potassium, whatever else your body has in it, and it's going to pool and it's going to attract. So it's going to dehydrate. So if you drink a lot of water, you're going to be urinating a lot because it's literally taking sodium and potassium outside of your cells. And because your kidneys have to balance your electrolyte to be the proper amount of water with the proper amount of sodium and the proper amount of potassium, the kidneys will either recycle or eliminate whichever that they need to do. If you drink a lot of water without sodium, which is very high in your blood, it's actually going to force your kidneys to remove that water right away. So you're going to keep on urinating. And every time you urinate, you're going to lose a little bit of extra sodium and a little bit of extra potassium because you cannot not to. The kidneys, the way that the kidneys recycle sodium, for example, is that they vasoconstrict. It's a very big work for the kidneys to cause constriction in the kidneys. And if you do this is why the low salt diets are really bad, because it forces the kidneys to recycle. And as the water is going through, it has to constrict, because the particular area where the water, where the kidneys recycle sodium, have little holes on the wall. And when the water is allowed to flow through with the salt and the salt is excreted, the hole is just big enough to allow the sodium through. But when the body wants to recycle the sodium because you don't have enough, say you drank too much water, but you didn't take extra sodium with it, it's going to constrict that pipe so that the little holes on the wall are going to be smaller, too small for the sodium to go through. This causes, you have to release the renin, angiotensin, aldosterone system, and that causes vasoconstriction. And so this is how you end up with hypertension, with high blood pressure. So if you're drinking a lot of water, you're dehydrating yourself and may end up with a high blood pressure. So the proper hydration is an electrolyte hydration. So drink salt and water. And when you drink salt and water together, and of course, this potassium in your blood has to be very small amount. It's about 33 times as much sodium in the blood as potassium. So there's more room for the sodium to move around than for the potassium. So the potassium average is about four. I think it's from 3.5 to 4.5 or something. And it's really equivalent per liter. And in sodium, it's 140 to 155, depending upon, what lab you're working with. So you can see it's a magnitude higher there. So you have more room to play with the sodium than you do with the potassium. So when you're looking at just drinking water, you're causing a lot of damage with your sodium. And so you really need to supplement sodium as well. And what I recommend in the group, we calculate everybody's water need. They can do it themselves, or we can help them. For men and women, it's different. We use the body weight with a certain percent. For the female, it's 55 to 60% of the female body is water. So we take your weight times 55%, and that's how much you have to drink in water in ounces. And then for men, their body weight is 70 to 75% water. So we take 70% for an average male, 75% for a very cut male, as their multipliers for their weight, as in total, as a minimum. And the maximum is whatever the total weight is. That's in ounces of water. So that's how we use it. And then each cup of water gets salt, either with the water or take as a capsule like I do.
Mm-hmm. Right. Let's cover some migraine-related myths. And there are so many of them. So are they more common in females than males? Is that fact or?
No, that's fact. And that probably has an evolutionary reason. I discuss that in the book a little bit when I'm talking about when you look at ancestrally speaking, the males usually after they reached adulthood, which was pretty young, usually in their early teens, right? They would become adult males and they would join the hunt. And so as a hunter, you have your hunting weapons and you're running after an animal. So your chances of being attacked by a lion in a corner are pretty minimal. So whatever anxiety you may have is associated with your run, fight, or flight that you are initiating, right? Mm-hmm. But when you look back at what the women and children were doing, they are in the fields squatting, they are in high danger from an attack from any kind of a predatory animal. And so they would have to have the hypersensory organs. So migraine is based on this hypersensory organ in the brain where your senses are much stronger than what is normal. And so these senses would be especially high in women who remained in the fields, and they are high in children. But the moment they step out of childhood for boys, it disappears. And if you look at the statistics today, most boys outgrow their migraine as they pass puberty.
Does the weather, say strong sun or heat, trigger migraines?
Yes. So there are several factors here. So the sun itself is because it's bright. And so if the person doesn't have proper electrolytes, it can be a stimulant to create a migraine because it's an oversensitivity, high light. But if you prepare for that, then the heat. So what does heat do? So when you go into a sauna, you go into a hot tub, you take a shower, it's a hot weather outside, you're coming from exercise. All of these have vasodilation effect. And so your blood vessels become bigger and your relative blood volume drops. So then, as far as your body is concerned in your brain, you are dehydrated. Even though you're not necessarily dehydrated, but because your blood vessels are muscles. Most people don't realize that they're muscles. So they can increase tremendously in diameter and reduce. So when they increase in diameter, think of it like a tube, a continuous tube in the body. When you change nothing else, but you suddenly increase the diameter of the tube all the way around, the amount of liquid that's in it is going to appear to be much smaller. So if this happens, and this can happen in heat, and it also happens when the barometric pressure drops, because then the weight of the atmosphere is less on you. So everything is kind of relaxing and your blood vessels will dilate. And so this can cause a discomfort and a migraine because it will cause an electrolyte disturbance because suddenly your blood volume is going to be dropped. So you want to increase your hydration, so salt and water extra when the weather is changing to hot or when the barometric pressure is dropping. But when the weather is changing to cold or the barometric pressure is increasing, the opposite happens. So when the pressure is increasing, then the weight of the atmosphere on you is becoming heavier. It constricts your blood vessels. And also when it's cold weather, your blood vessels what used to pop out of your hand and you could see it very much on your arm, suddenly disappear. They move deeper, they literally move deeper inside to prevent heat loss through the blood. And they become much smaller. They get vasoconstricted. So in this case, then you're suddenly going to end up with too much water or liquid in your blood vessels. And so that's going to give a pressure on you. So in this case, you want to reduce the amount of water that you're drinking, because you don't want to increase your blood volume. So there are some factors in there. There's a lot of caveats that you have to observe, but once you get it going, and also if after years of being on a proper diet without carbohydrates and all the nasties that we haven't talked about, then your body adjusts and your tolerance to these changes, it increases. And so you have less of a problem to pay attention to.
Mm-hmm. Well, it's probably similar mechanism with mine, with the next one on my list, which is about strength training triggers migraines.
So training is interesting. Before COVID, I would train all the time. I used to lift weights and I was very good, very, very strong. I was up 175 pounds of lifting and deadlift, which was really good. And I really loved it. And now I switched to just jogging, and I'm jogging like crazy 3 miles. And I think that is not just the strength training, but it could also be endurance training. So they're slightly different in what they accomplish, but I think they're equally good for migraine, especially because the cause of migraine, which is the electrolyte imbalance, is really caused by a fight or flight that is released. So for example, if you have a sugar crash, you said earlier that your body releases glycogen in response to that sugar crash. But how does that do that? It does it because the sugar crash itself initiates a fight or flight, which releases adrenaline, and the whole thing starts pumping, which then, and epinephrine, everything is going. And then suddenly your liver and your muscles release a ton of glycogen, too much actually, like 20 times as much as normally. And so when you're looking at exercise this way, fight or flight is what initiates the migraine. So if you're actually flying, which is fight or flight, right? You're flighting, you're running, or fight, which is lifting weights. It's the same activity. You're actually working those very muscles that you're supposed to be working, right? And when you're working those muscles, you're using up all that extra energy. And so in addition to the benefits that they have, these exercises have for your muscles and for your general how well you feel, they can prevent a migraine. And in fact, if midstream of a migraine, if it's not yet too bad, you start to exercise, you may be able to avert it as well, because you are then using up all that glucose that was released, and it doesn't have to go into the cells. It's going to be used up by your muscles and your heart instead of having to be squished into the cells, and it won't release a whole lot of sodium and water. So it has a benefit. Plus it releases, all kinds of factors in your brain, which relaxes you and allows you to sort of return to a normal state. So it has a lot of benefits, whichever exercise you do. And they're somewhat different. And I think that difference will be dependent on the person, or whichever is more comfortable for the person.
Fascinating stuff. You mentioned we talked about heat and the barometric pressure. How about full moon?
Okay, actually, full moon does. And so everybody misunderstands because they think that people go nuts in a full moon. And that's not true. Nobody goes nuts. Yes, there may be more crime committed in a full moon, maybe more accidents in a full moon, but that one, they will have different reasons. And so people say, well, you can't possibly have any full moon effects because the amount of water in your body is too small and it's constrained in a small place. So yes, physiologically, none of that is happening. It's not a physiological thing. But what it is that during a full moon, you have very bright light. Have you ever seen a full moon next to the street light? Because I've taken a photo once.
I saw that.
Well, like many years ago, the full moon and the street lights, you'd probably have to put together 15 to 20 street lights side by side to get the same strength as the full moon. So the full moon is like a flashlight. And most predators hunt better when they can see better. And so as a human, we were subject to predators, right? They were predated on. And so during full moon, we were killed by the lions and the tigers and whoever else. And in fact, I was watching a YouTube from some ancestral video. Somebody visited this ancestral group, but I don't know where they were anymore. And the guy was asking, so what is the most important thing? And the guy says, it's meat. And the guy says, so what are you concerned about? Full moon. And, and on and on and on. And he said, well, why full moon? It's because then they're visible for the animals. And so it's working against humans, even not just from being predated on, but also if you want to catch something, you'll become visible at night, so you can't hunt so well. And so full moon has a psychological effect on humans of being subject to more danger. And therefore, the fight or flight initiates in full moon for migraineurs. And that causes a problem. So, but all we have to do really is buy a kind of curtain that's blacked everything out. And as long as you don't see the light, it's not going to bother you. So it's not like, okay, full moon, so I'm affected. It's the light of the full moon that is affecting.
Right. So migraines disappear after childbirth. Obviously not true.
I don't know. Said that to me?
Why do so many people say that? Why do so many people? I think they said that to you too, didn't they?
Yes, they did. And mine got worse after childbirth. So I don't know where they get that. I think it's coming from the very beginning of our conversation, is that there are two parts to it. The first is that a lot of misdiagnoses are out there. So it's possible that certain stress headaches disappear after childbirth, or although having children for a number of years, that stress is going to increase, but that's another story. But so I don't know who said that and why they said that. But on the other hand, there's a sad side to this, which is highly likely. So I have been going to many conferences and presenting, posters or making presentations. And so I never forget this couple coming to me, and one of the places where I was presenting. And she said, she walked funny. So you could tell how she was walking. You know how you can tell when somebody is cognitively compromised a little bit by the way they're walking. They're holding their hands a little bit different, and they take smaller steps. And so they somehow become weaker looking, fragile. And she was looking like that. And she was heading to my board, and we were talking, and she said, oh, I no longer have migraines. And I said, well, how old are you? And I think she said 68 or something, so younger than I am now. And I looked at her, and I didn't see anything. I didn't want to hurt her. But what this actually means, given what we know about migraine brain having more connections between sensory neurons, if you stop having migraines without any changes otherwise, that would mean that you are already suffering a cognitive decline. These connections are breaking up and disappearing. That's not a good sign. That means that your brain is degenerating. You don't want that. I'm very happy that in my 70s, I still get migraines. Bless you. I am still not cognitively declining. But yes, if you start not having migraine as you get older, that's not a good sign.
What role does menopause play? Does it make, or perimenopause and menopause, does it worsen migraines?
In my experience and several other women of my age, it did. My migraines got a lot worse. I mean, I entered my menopause very suddenly because I needed to have complete hysterectomy, which was part of metabolic disease that nobody told me at the time. But I was only 42 when I needed to have complete hysterectomy. So technically, I was postmenopausal at age 42. But my migraines didn't get to be really bad until age 50, 55. So it was completely independent. Now, why people are saying this is because there are women who have huge hormonal migraines. So what does that mean? It doesn't mean that the hormones create the migraines. What it means is that the hormonal changes create a cycle of electrolyte changes in the body. So for example, when a woman is estrogen dominant a certain part of the month, what does estrogen do? Estrogen holds onto sodium and water, because its job is going to be to support the clearance, right? When it's progesterone dominance part, what does it do? It releases all the sodium and water. And so what we do is we have our female members who are still part of, and even after they passed menopause, because weight changes happen, we have them check their weight on the scale every single day. And so like I have a scale that tells me what I was the day before and the day before. It shows a graph for me, and it also shows it to me on my phone. And so I can see how much weight I changed. And I will have quite a bit of fluctuations based on weather. Like we had Santa Ana winds last night. I retained a lot of water this morning. I looked in the mirror and said, oh my God, I'm going to have an interview with you. And I looked like I was hit in the face because I retained a lot of water from the Santa Ana winds overnight. I gained like 3 pounds, for example, out of the blue for no reason. Of course, I know how to get rid of it and no longer have that kind of a face, but it was really scary in the morning. So if you still have period, you can judge whether even to the hour of when you're going to get your period, because when you stand on the scale, you check it every time in the morning, naked, after you went to the bathroom, before you eat and drink. So you're totally just as much as possible your weight and nothing added. And you compare every single morning to other mornings. And then you can see the changes. And if there's a significant change, and so significant change would be if you're gaining weight about 2 pounds or more, like 1 kilo or more, that would signify that your retained salt and water, for whatever reason, it could be estrogen, or like in my case, because of the very dry, hot air that's coming through with the winds, my body prepared for that and I retained that. If you lose weight, then it's the other way around. You're dehydrated. You need to add and double up your salt and water for your morning because you're dehydrated. So you can, once you understand how the system works, you can actually prevent it. And so this would be the connection to menopause, in that perhaps in menopause, it is assumed that these are reduced because your hormonal fluctuations are reduced. However, what we find is that while your sexual activity hormonal fluctuations may reduce, but your hormonal changes don't reduce, because you still have estrogen. Even after all the surgery you have, and you no longer have any female organs, as long as you have breasts, you still have estrogen. And you still have estrogen because of your female brain. So you can't get rid of estrogen completely. And so you still have some cycling. It may not be as big as you would have it from if you had active period, but you still have some cycling.
You mentioned prevention. Let's talk about prevention, because prevention is about catching the early signs. And then you covered it. Okay, so these are, we're going to call them, like Angela does in the book, prodromes. So prodromes are noticing and observing the early signs and preventing a full migraine onset, flare-up. Is it a flare-up?
Right. Well, it's an onset. So it's not really a flare-up. It's like an onset. It's when the actual migraine will start. And so you can have a prodrome 2 days prior to a migraine, or you can have it just a minute before a migraine. So it depends upon the prodrome. So you have to be ready and pay attention to anything. It's quite difficult. I would say that 99% of the migraineurs don't know what their prodromes are. And by the time they're catching them, it's too late. So the prodromes that you want to catch are, for example, what we found in the group was fascinating. My husband, of course, I've been married now for 49 years. And so he's known my face. We've been together for 51 years. Okay. So he knows my face, right? And he used to tell me, you have a migraine face. And I said, what is a migraine face? I didn't know. This was like 10, 15 years ago. I said, what is a migraine face? And he says, I don't know, but it's different. And so it took some time. We figured out that one of my eyes, my right eye, which I don't have symmetrical eye completely. This is always somewhat different, but it would be like this. I'm trying to, like tortoise, it sort of kind of close off. That would be my face before a migraine. It would be like this, sort of kind of, that I would not be able to open that eye. And I never noticed it because I'm looking at my face and it's always the same to me, right? I'm looking in the mirror and it's nothing different. And he just realized that something was different, but he didn't know what it was. And it took some working out, taking photos, whatever. Finally, figured out, this eye gets smaller before a migraine. So I already had my group, because on my first edition of the book, I already wrote about this. And in the Facebook migraine group, I mentioned this. And then we took a survey, and just about everybody has it, but they just didn't notice it. So people kept on putting their selfies in. I said, wow, look at me. Do I have this? Is this what you mean? and kept on doing it. And they would put in 2-3 photos, like this is when they don't have it, this is when they have it. And so it appears to be a universal migraine prodrome, that one eye becomes smaller than the other, or smaller than it used to be otherwise, for the time of before the migraine occurs. And so this is probably associated with the lack of salt. So the muscles are not working, from the instructions from the brain are not coming to open this eye. I haven't found a better explanation for that. So that's possibly the reason. So this is one symptom that nearly all of us have. It's really amazing that we do. Another prodrome that most of us have is that we will urinate a lot more because we have an electrolyte imbalance and the kidney wants to balance. So we're going to urinate because the kidney wants to bring it to balance. And our urine is not going to have the proper color. So the proper color would be like a light lemonade kind of a color. And when we urinate, it's going to be clear, like almost transparent. That means you're just dumping water because you don't have enough electrolyte and your kidneys are trying to recycle your sodium. Another one, of course, is nausea, vomiting, dizziness. Some people have aura. Of course, most migraineurs have some visual disturbances that are not called aura. They're syncytial stachoma, but I call them aura because nearly all of us have something. They could be like, I love my fireworks. They like, it's like, but just in one eye, mine are blue and just shine up like fireworks. It's really pretty. Or like in the middle of the night, I may get a flashlight, like hitting somebody from behind. And I wake up and say, was this a lightning or something? Then I realized it was just a flash in one eye. Usually the eye that gets smaller. And then I know that is a migraine prodrome. So you may have a lot of prodromes. And so while you have these prodromes, when you have them, if you then take a salt test. So the salt test is you take a very little amount of salt and put it under your tongue. Just don't drink, don't talk, just put a little salt under your tongue. And it's going to absorb, and it will go directly into your blood circulation and into your brain, in your mouth. And if you find your prodrome lessening, then take more salt. If your prodrome increases, that means you need potassium. So for the coconut powder, coconut water powder, or eat an avocado if you eat plants, or eat fish, or eat steak. These are the high potassium food items. If there's no change, then I call it the hit it with both. So get a food like a big steak, salt it properly, and eat that. And now you also need to know what you ate before, because if you ate carbohydrates, you don't want to have water and salt for carbohydrates, because what does carbohydrate do? As glucose enters the cells, it removes sodium and water. So if you take sodium and water, you already have a lot of sodium and water in you, just not in your cells. So you can't bring the sodium back, but you can bring the water back if you take salt. So then you just take salt, no water. And it's going to bring, that's what I did today when I had those big things. I just had salt and it pulled everything back. And so it's fantastic. So you can totally prevent everything if you observe your environment, you know what you ate, keep records of what you are eating, because when you have a migraine, you're going to forget. You won't be able to think back of what you ate 5 minutes ago, let alone a night ago. You have to go back about 24 hours to see what you ate and drank to evaluate why you have a migraine. Look at also the weather. If there's a weather change, look at your period, the cycle, look at if there's full moon, look at if there's any stress, if you are sick or about to become sick, or somebody else is sick. So all these factors count in, and you will have to adjust what you do based on understanding your circumstance.
Another prodrome you mentioned, I think this was under prodromes, was the temporary paralysis. That's scary. What kind of paralysis are we talking about? Like stroke?
It's a stroke type paralysis, half of your body, and that's a hemiplegic migraine. So it can be, when I had people coming into the group, joining the group, we ask them that if they are hemiplegic migraineurs, they have to send me a private message, because oftentimes they get a hemiplegic migraine and a spouse or a friend is going to contact me. What do I do? And so I like to be on with them right away. And so what I find is that unlike a regular migraine, with a hemiplegic migraine, they always need salt without exception. So I had a migrainer once who was in the hospital. She collapsed. She was a elementary school teacher. She was a hemiplegic migrainer and she collapsed in the bathroom. And they found her. She was completely out. And they took her to the hospital, to the emergency. She was completely out. They thought she had a stroke, but then they checked her, and they discovered that she doesn't have a stroke, so it must be a migraine. And they were trying to give her all kinds of medications, and the husband said no. This was in another country. This was actually in Taiwan. And the husband said no, and he sent me a message. What do? I said, put salt into her mouth. So he ran out, and there's no salt in Taiwan. So he had to run to get a little packet of salt and just poured it into her mouth under her tongue. And within half an hour, they snuck out of the hospital. She was completely fine, completely recovered.
Okay, so blurred vision, urine color, now the odors. Is that, we're talking about body?
Any odor.
Oh.
No, any odor. So anything that we smell. So it could be like an air freshener, cologne, anything whatsoever. So our body odor is not necessarily, but if I'm with you and you have a body odor, I may get a migraine from that because it overstimulates.
Right. So tingling in the face, hands and feet.
That's typical for hemiplegic migraines. So I'm not a hemiplegic migrainer, but I sometimes get tingling in one arm. And so this is also important, as we talked about migraine types, is that everybody can have any kind of a migraine. And so a migraine is really dependent on the type of migraine. Is really like hemiplegic just means it is affecting a brain region that affects the muscles. And so you can't stand up, you become paralyzed on one side. But the same effort, this migraine can be, for example, in the speech, the Broca area, when that just means you can't speak. Or it could be in the visual cortex, which means you're going to end up with an aura. So depending upon where the migraine is located, the symptoms will differ. So the migraine is always the same. It doesn't matter if it is where it is at. The symptoms will differ, but the same migraine, regardless. And so the treatment isn't different. They're always the same treatment because they're all the same things. So the tingling means a hemiplegic migraine is about to come. So it can be I had tingling in my arm and in my leg, and so I knew it was a hemiplegic migraine, but I never had a hemiplegic migraine before. And of course I prevented it, so it never happened. But this was an unusual symptom for me. So anybody can have any kind of migraine at any given time.
Now, tinnitus and Meniere's disease are other things you mentioned. Now, I haven't written the details next to those, but are they actually early signs of migraine onset? If you have vertigo and dizziness, because I just didn't understand that tinnitus and, well, let's start with Meniere's. One of my closest friends actually suffers from it. Could he be having migraines and no one seems to know because his like Meniere's disease, when he suffers, it stays with him for 2-3 days. He's sick for 2-3 days. Could that actually be migraine?
Well, it depends. So if he has a migraine brain and if he has other symptoms as well, then it can be, depending on the other symptoms. But if he just has Meniere's, again, then we get into the problem of having so many of these prodromes, the same as other diseases, that people tend to be diagnosed with a ton of different diseases. But Meniere's is a disease on its own. And so it can be a prodrome for those people who have sensitivity for Meniere's disease. So it isn't like everybody will have Meniere's disease, or like all Meniere's disease will be a prodrome for a migraine. It's like these are separate things. And there's a small population where the two overlap, where they are migraineurs and a Meniere's disease may be a prodrome for a migraine.
Another overlap is, of course, Raynaud's syndrome.
Right, which I have. Thank you.
My husband has that. So, and migraines. What's the overlap there?
Right. So this is genetic overlap. So comorbidities. So I looked through, there is a human genome database. This is genecards.org. And I spent years looking at the different variants, and I haven't looked now for about 5 years. So I need to go back and see some of the overlaps. But what I did is I went through all the genetic variants that was listed under migraine. And also I looked at Raynaud's, and I looked at EDS, which we talked about earlier, and one more, urticaria, because urticaria, which is itching and rashes from temperature changes, was also very frequent in the migraine group, particularly cold urticaria. And I have all of the above. And so I wanted to see, is there a genetic overlap in these? And what I found is that migraine and Ehlers-Danlos syndrome at that time, like whenever I was doing this comparison, was 5-7 years ago, there was a 70 to 80% overlap in genetics, which means that a person with EDS, which had a smaller genetic database for EDS than for migraine. So I was looking at each and compared and looked to see if they are within migraine. So if you have EDS, there's a 70% overlap with migraine. So you may end up with migraine as well. So if you look at, for example, the definition of EDS, they incorporate migraine in it because there's just so much overlap. When you look at Raynaud's, I think it was 50 to 60% overlap. And when I looked at urticaria, I think it was like about 40% overlap. So there were like huge overlaps. So it doesn't mean that if you have migraine, you're going to have any of these. But if you have any of these, you may also have migraine. So that's how this overlap actually works. And so now these, the urticaria and Raynaud's are also falling in the category of autoimmune diseases. And so as autoimmune diseases, they can disappear if you stop eating those food items or whatever that you're taking that is affecting your immune system in a negative way, it can reverse. So for example, for me, the cold urticaria disappeared completely. I haven't had one since. But the Raynaud's is still there, so that didn't disappear. And EDS is, of course, still there and didn't disappear. But so these can, in fact, be comorbidities with migraine, but they don't have to be. So you may have a lot of people who have only Raynaud's, like my cousin who only has Raynaud's, because this too is running in the family, it's because it's genetic. She has had Raynaud's, never had a headache or migraine in her life. So it isn't necessarily, one doesn't follow the other necessarily, but there's a higher likelihood.
One last major question actually is the stomach bugs you mentioned.
Right.
Or food poisoning, for example.
That's completely independent. But what happens is that like when I was a child and I had a lot of irritable bowel syndrome, I was misdiagnosed because my mother would be told by the doctors, oh, she probably ate something and it's probably food poisoning. When in fact, now I understand it was a cyclical vomiting syndrome and irritable bowel syndrome, which is the childhood manifestation of migraine. One form of childhood manifestation, or two forms, the irritable bowel and the cyclical vomiting syndrome. So these two don't necessarily follow to adulthood. So they will be very specific to children. There are some people for whom it will continue to adulthood, but very rare. And so in this case, these would be migraines in and of themselves. They may not need to have other symptoms with it, or they may. So most of the children in my group who are there with their parents, so they themselves aren't in there and have irritable bowel syndrome or cyclical vomiting syndrome, have other migraine manifestations as well, like pain.
Angela, this has been a wonderful, wonderful discussion. Now, you do say in the book, I think I'm quoting you here, if I know what causes it, I can stop it.
Right.
So can we stop migraines for good?
Absolutely. For good. Absolutely. Yeah. Now, the for good has to be taken with a caveat, because if you change your lifestyle and you go back into eating the standard American diet, then you're back into the migraine world. But if you don't change your diet, like I test my limits. Like this summer, I spent my time eating a lot of fruits that are not on my protocol because I wanted to see if my tolerance has changed. and how I respond to carbohydrates. And I came close to migraine a couple of times, but it took me like 2 months of eating a ton of watermelon, for example, to get there. Okay. So, and I did eat also sugar. I went to my birthday party when I turned 70, and some of my friends from from Australia came, and locally, and we met in San Diego at the conference for that matter. And we celebrated, and I wanted to eat, I think it was a flan, something like that. And so I ate sugar this year, which I normally don't do, but this time I did. And also, like I said, I went crazy this summer with watermelon because I wanted to see what it was like. And yes, I still can get a migraine. So I have come to the point of close enough where I felt that, okay, I'm getting too close here. And I had quite a bit of higher tolerance now than I did when I started. So my body has given me an allowance now, because even though I'm still chasing a certain amount of sodium and water out of my cells as the glucose is going into the cells, it's my body is working more efficiently. I have less insulin to achieve the same role. And so I had a quicker clearance somehow. I had very quick reactions. Like the first signs I felt from eating carbohydrates was swelling of my ankles. It was like within a minute, I could feel that my shoe started to feel tight. It was really a fascinating thing. But then all you have to do is take some salt without water, and then you're going to feel within 10 minutes it's going back. So you can totally control it, and you can remain migraine free for life as long as you observe some of these rules.
Thank you so much for this wonderful conversation. I will put all of your links in the description, and I will put the direct link of your book, and I highly, highly recommend that you buy the book. You will learn so much, not just about migraines, but about metabolic disease. Angela, once again, thank you so much. I really appreciate your time.
Well, thank you for inviting me. It was fantastic. Great conversation. You had fantastic questions. Thank you.
Thank you. Bye for now.
Bye now.